Cervical cytology is the microscopic examination of cells collected from the uterine cervix. The Papa-Nicolau test, commonly called the Pap test or Pap Smear, is used to detect squamous and glandular epithelial abnormalities and to identify patients who require further investigation. The Pap test is a screening test, not a definitive histopathological diagnosis. Cytology evaluates individual cells and cellular groups, whereas histopathology evaluates intact tissue architecture, the epithelial-stromal relationship, and stromal invasion. Therefore, cytology may suggest an intraepithelial lesion or malignancy, but confirmation and assessment of invasion require an appropriately obtained tissue specimen. Cervical cytology is based on the principle of exfoliative cytology. As cervical epithelial cells mature, they migrate toward the surface and are eventually shed. During specimen collection, spontaneously exfoliated cells and cells mechanically dislodged from the epithelial surface are obtained for examination. Cytological interpretation depends on features such as cellular size and shape, nuclear to cytoplasmic ratio, nuclear membrane contour, chromatin pattern, cytoplasmic maturation, cell cohesion, and arrangement. However, the diagnostic value of these features depends entirely on whether representative cells have been collected and adequately preserved. Thus, a technically satisfactory Pap preparation requires both representative sampling and preservation of cellular morphology, transformation zone, and specimen collection. The principal target of cervical sampling is the transformation zone, because most cervical squamous intraepithelial lesions and squamous carcinomas arise in this region. The squamocolumnar junction, or SCJ, is the interface between ectocervical stratified squamous epithelium and endocervical columnar epithelium. The transformation zone is the area between the original and current SCJ, where exposed columnar epithelium has been replaced by metaplastic squamous epithelium. Squamous metaplasia is a normal physiological process and must not be confused with dysplasia. However, immature metaplastic and reserve cell populations within the transformation zone are particularly relevant to persistent high-risk HPV infection and the development of precursor lesions. The position of the SCJ changes with age and hormonal status. During reproductive life, it is usually accessible on the ectocervix. With increasing age and after menopause, it commonly recedes into the endocervical canal. The sampling technique and collection device must therefore be selected according to the location and accessibility of the transformation zone. The objective of collection is to sample the entire transformation zone while obtaining both ectocervical and endocervical cellular components where anatomically appropriate. An Ayre spatula is designed primarily for ectocervical sampling. Its longer projection is placed within the external os, and the spatula is rotated firmly around the cervix. An endocervical brush samples the endocervical canal and is commonly combined with a spatula when separate ectocervical and endocervical sampling is required. Excessive insertion should be avoided because it may produce bleeding and unnecessary endometrial or lower uterine segment contamination. A broom-type device contains central bristles for the endocervical canal and longer peripheral bristles for the ectocervix, allowing simultaneous sampling of both regions. Blood, mucus, inflammatory exudate, excessive lubricant, traumatic collection, poor cellular transfer, and failure to sample the transformation zone can all reduce specimen quality. The sample must also be correctly identified and accompanied by relevant clinical information, including age, menstrual or menopausal status, pregnancy, previous cytology or histology, prior treatment, and hysterectomy status. Conventional Pap smear and liquid-based cytology. After collection, the specimen is prepared either by the conventional smear method or by liquid-based cytology. In a conventional Pap smear, cellular material is transferred directly from the collection device onto a glass slide. The material should be spread evenly and fixed immediately, usually with alcohol-based fixation. Delay in fixation produces air-drying artifact with loss of cytoplasmic transparency and distortion of nuclear detail. Conventional preparations may show uneven cellular distribution, thick areas, overlapping cells, and obscuration by blood, mucus, or inflammation. However, they are inexpensive, preserve the conventional cytological background, and remain diagnostically reliable when properly collected, transferred, and fixed. In liquid-based cytology, the collection device is rinsed or placed in a vial containing preservative fluid. The specimen is processed in the laboratory to produce a thin, relatively uniform cellular preparation. Compared with conventional smears, liquid-based preparations generally show a smaller and more defined screening area, more even cellular distribution, reduced cell overlap, a less obscuring blood, mucus, and inflammatory material, reduced air drying artifact, and residual material that may be used for HPV testing or other ancillary studies. However, liquid-based processing may alter familiar morphology. Cellular groups may appear smaller or more compact, extracellular material and tumor diathesis may be reduced, and cells may show altered spatial arrangement. ThinPrep and SurePath also differ in processing technique and in some background and cellular characteristics. Liquid-based cytology offers important advantages in preparation quality, standardization, and ancillary testing, but it should not be described as universally more sensitive or more specific than a well-prepared conventional smear. Regardless of the preparation method, interpretation cannot begin until the specimen has first been assessed for Bethesda Specimen Adequacy. Bethesda Specimen Adequacy. Specimen adequacy is assessed before cytological interpretation and is a mandatory component of the Bethesda report. Since the 2001 Bethesda revision, adequacy has been classified into two categories: satisfactory for evaluation and unsatisfactory for evaluation. The former category of satisfactory but limited by is no longer used. A satisfactory specimen must contain sufficient well-preserved and well-visualized squamous epithelial cells. The estimated minimum cellularity is 8,000 to 12,000 squamous cells for a conventional smear and 5,000 squamous or squamous metaplastic cells for a liquid-based preparation. These are estimated thresholds based on representative fields or reference images. They are not obtained by counting every cell individually. For a satisfactory specimen, the report should also state whether an endocervical or transformation zone component is present. This component is defined by at least 10 well-preserved endocervical or squamous metaplastic cells, present singly or in groups. However, absence of an endocervical or transformation zone component does not make the specimen unsatisfactory. It is reported as a quality indicator because its significance depends on the patient's age, transformation zone location, and clinical context. An important Bethesda principle is that the presence of an epithelial abnormality overrides the numerical cellularity threshold. If abnormal cells are identified, the specimen is considered satisfactory for evaluation, even when the overall squamous cellularity is low. Unsatisfactory specimens and important adequacy pitfalls. A specimen is reported as unsatisfactory for evaluation when reliable interpretation cannot be performed. The report must specify whether the specimen was rejected without processing or was processed and examined but remained unsatisfactory. Specimens may be rejected because of absent or incorrect identification, a broken slide, improper fixation or transport, specimen leakage, or failure to provide essential specimen information according to laboratory policy. Among processed specimens, the most common cause of unsatisfactory interpretation is scant squamous cellularity. Other causes include obscuration of more than approximately 75% of the epithelial cells by blood, inflammation, lubricant, or contaminating material, severe air drying or fixation artifact, excessive cytolysis, marked cellular degeneration, thick preparations with extensive cell overlap, and technical processing failure. Partially obscuring blood or inflammation does not necessarily make the specimen unsatisfactory. If sufficient epithelial cells remain clearly visualized, the specimen may be reported as satisfactory, with the obscuring factor documented as a quality indicator. The standard 5,000 cell threshold for liquid-based preparations should not be applied rigidly to every specimen. Atrophic postmenopausal samples, vaginal samples, post-hysterectomy specimens, and specimens obtained after radiation or chemotherapy may normally contain fewer cells. In these situations, adequacy requires cytopathological judgment. Samples containing fewer than approximately 2,000 cells are generally unsatisfactory in most circumstances, but the specimen type and clinical setting must be considered. A vaginal vault specimen after hysterectomy does not require an endocervical or transformation zone component. Similarly, adequacy is assessed for each slide individually. Cellularity from several inadequate slides should not be added together to create an apparently adequate specimen. The major practical errors are therefore clear. Absence of transformation zone cells should not be called unsatisfactory by itself. Low cellularity thresholds should not be applied inflexibly to special specimens. An obscuring material must be judged according to how much of the epithelial component remains interpretable. Before concluding this lecture, let us summarize the essential principles. Cervical cytology is a screening method based on the examination of exfoliated and mechanically collected cervical cells. It evaluates cellular morphology, but does not preserve tissue architecture or establish stromal invasion. The transformation zone is the principal sampling target. The squamocolumnar junction is a line, whereas the transformation zone is an area between the original and current junctions. Squamous metaplasia is physiological and must not be confused with dysplasia. The Ayre spatula samples the ectocervix, the cytobrush samples the endocervical canal, and a broom-type device samples both regions simultaneously. A conventional smear requires immediate transfer and wet fixation. Liquid-based cytology produces a smaller, more uniform preparation, reduces obscuring material and air-drying artifact, and preserves residual material for ancillary testing, but it is not inherently more sensitive or specific than a properly prepared conventional smear. Bethesda adequacy is assessed before interpretation. The estimated minimum squamous cellularity is 8,000 to 12,000 cells for a conventional smear and 5,000 cells for a liquid-based preparation. At least 10 endocervical or squamous metaplastic cells define a present transformation zone component. Its absence does not make the specimen unsatisfactory. A specimen is unsatisfactory when cellularity is markedly scant, when more than approximately 75% of the epithelial component is obscured, or when fixation, preservation, preparation, or processing prevents reliable interpretation. Finally, the presence of abnormal cells makes the specimen satisfactory for evaluation regardless of the usual numerical cellularity threshold. With specimen collection, preparation, and adequacy established, the next lecture will begin the systematic interpretation of cervical cytology under the category negative for intraepithelial lesion or malignancy. Thank you for watching. I will see you in the next lecture.